for yielding and for holding this hearing on such an important topic. The transition to value-based care, as envisioned under MACRA, has left a lot to be desired. And I would like to thank Dr. Fowler for appearing today, as well as the committee for looking into ways to improve the value-based care pathway and how we can improve both quality of care and outcomes for American patients. Dr. Fowler, looking at the latest data that we have from 2022 performance year, the vast majority of physicians are still stuck in the MIPS program versus participating in an APM. To the extent that we've seen increases in APM participation, it seems like that it is mostly driven by expansions of existing APM models instead of the creation of new options for those who are looking to participate. In your view, is CMMI doing enough to get doctors into advanced APMs?
Thanks for that question, and thank you also for extending the bonus payment for APMs. I think that's an important incentive to join those programs. We aim to move as many providers as we can into APMs, and that's one of our stated goals. And are there enough models for everyone to join? Perhaps not, but I think we're continuing to think about how we can do more to incentivize.
Are you looking to create new models? Are you looking for more opportunities to engage physicians and practices to participate?
We are, and I think in forthcoming rules, hopefully we'll give more signals about some potential directions.
What's the timeline? What are we looking forward to seeing those, please?
We have said we want to see all Medicare beneficiaries in accountable care organizations or advanced primary care by 2030. That will necessarily involve including specialists and engaging specialists in value-based care, and so we're looking for additional pathways.
Is there additional pathways to expedite that closer to 2030?
We hope so. We're looking at that.
I think that's something that we need to. Moving on, the Physician-Focused Payment Model Technology Advisory Committee, PTAC, was established to review and evaluate physician-focused payment models that could be adopted to improve value-based care. Many specialty physicians have invested significant time and significant resources to develop these models and submit them through PTAC. However, there is a significant gap between the PTAC's recommendations and the implementation of these models by CMMI and CMS. Can you explain why CMI or CMS has largely ignored the PTAC recommendations, and what steps are being taken to ensure that these valuable insights and innovation models proposed by specialty physicians are given the consideration that they need?
Thanks for that question. We see PTAC as an important partner. I was just at their meeting and spoke publicly at their forum on Monday, and there was a specific panel that they had organized for CMMI to appear and share some of the learnings from our specialty care models and our models that target seriously ill and chronically ill populations. We have reviewed, and some of this happened before my tenure here, we have reviewed all of the recommendations, and their recommendations have informed a number of our models, including in the kidney care space, the oncology model, and our primary care model, the primary care first model. We look at all of those recommendations and have incorporated as factors that as many as we can into the work that we do.
And I want to acknowledge and congratulate you on that collaboration, because I think that's incredibly important. In my home state of Pennsylvania, the Pennsylvania Rural Health Model is set to wind down at the end of this year. CMMI has made it clear that it would be sunsetting models like the Pennsylvania Rural Health Model, instead of focusing on additional advancement to these. So instead of continuing to engage with providers in my state to better address rural healthcare challenges, CMMI is replacing the Pennsylvania model with a one-size-fits-all, equity-focused model. Collaborating with state governments should be an important part to be able to recognize what providers can provide into this situation and work better with the state models. How do you expect this change to help rural patients in my state?
Thank you for that question. We're currently in discussions with the state of Pennsylvania about what happens to the Pennsylvania Rural Hospital Model.
Did you see benefits from that model?
We think that there were benefits to the model, in particular.
But then switching to a one-size-fits-all, how do we take those benefits and move them into the next model that should be available?
So unfortunately, the PARM model did not generate savings on a net basis, and so it's not a model that we can continue. We have offered to work with the state of Pennsylvania and figure out what comes next, and make sure that there's a smooth transition.
What timeline should we expect to see that model for rural states, like rural districts like mine in the state of Pennsylvania?
The PARM model includes a 2-year transition automatically if the state and the providers in the state choose to take advantage of the transition, and we're in discussions whether that's sufficient time or whether we need more time, and also thinking about what comes next.
My time in this questioning has expired. Again, I thank you for appearing here today. Mr. Chair, I yield back.